metabolic and renal disease. Prior to his current position, he was senior principal scientist at AstraZeneca, and he's currently the chief scientific officer at Antaros Medical, where he's been involved in designing clinical studies and imaging endpoints with MRI and PET scanning, and he's currently engaged with the Stravinsky Institute for Liver Disease and Metabolic Health, and we are happy to have him talk today about a holistic view of metabolic disease and treatment monitoring using imaging.
Thank you for that introduction. And yeah, here are my disclosures. I'm an employee and shareholder of Antaros Medical. So let's see. There we go. So I'll start this presentation with some work that I've been only remotely involved with, but I think it's important for today's discussion. And this is a study which I come from Gothenburg in Sweden, which was run out of Gothenburg. And this is a Swedish obese subject study, which started in 1987, looking into effects of bariatric surgery. With a follow-up of over 30 years since its start. The inclusion criteria you can see to the left, 37 to 60 years, and BMI about 34 and 38 respectively for males and females respectively. The primary endpoint was overall mortality, but there's also a lot of other endpoints like cancer, quality of life, kidney disease, etc. Now, with this very long follow-up and the couple of thousand subjects been included into the study, this are really what came out that's been shown, that what are the benefits of weight loss, and the long-term effects was published already back in 2004, so now 20 years ago, on long-term weight loss and reduced overall mortality, reduction of cardiovascular events, overall cancer, prevents diabetes, etc., and end-stage renal disease. And what you see to the right in the follow-up, where you can see the difference and the prolongation of the lifespan by weight loss induced by bariatric surgery. And the reason I'm talking about this is there is a lot of data on the health benefits related to this, and now in the era where we see of weight loss drugs being developed, I think it's really important to keep in mind what we learned already from this study with over 30 years follow-up and other similar studies. And one particular thing which we thought was very interesting is in the paper, that if you see who are the ones that benefit from weight loss by bariatric surgery, and this was nicely shown in the JAMA paper from 2012 by Lars Sjöström. And what you see there is that it's not the baseline BMI, it's not the LDL, it's not the HDL, it's not TG or lipid profile. Really, the only thing that predicted who will benefit on cardiovascular events are those with high baseline plasma insulin levels, speaking to the importance of insulin resistance in predicting who will benefit from bariatric surgery and weight loss. And we know that metabolic disturbance such as obesity and type 2 diabetes affect multiple organs. And in these clinical trials, end organ damage is usually studied in individual patient populations. But this is just to give you an example that you could have, and I'm sorry for I seeing now I haven't updated it with the new nomenclature in terms of MASLD and MASH. My apologies for that. But in this case, you could have a patient like patient 1 where you don't have overt chronic kidney disease, but microalbuminuria. Same patient may have elevated liver fat, but not overt MASH. overt MASH, but some diastolic dysfunction and the suffering from HFpEF. And there are, of course, all kinds of combinations of these. We will, however, indication that when you study this, you do study one patient population at a time, and then we try to sample things. What we are trying to do is using imaging to get a little bit more holistic view of what's happening with treatment in these patient populations. So this is where I started to work on this. This is data when I joined AstraZeneca in 2004. We started to work on PPARs, and this was a project which was later stopped. But to set up the analysis tools back then, we thought we could do better than what you do with DEXA and get a better understanding of what's happening to different organs. So what you see here to the left is one of the patients undergoing bariatric surgery. We took that as a model system to develop the methods. And what you see to the left here is a patient. To the left, you see with all the subcutaneous adipose tissue, and to the right, when we have by computer help removed all the adipose tissue, and you see what's underneath. And today, this is again 20 years later a very hot topic on what's happening with muscle mass during weight loss. And what you see here, I'll show you this as a movie. We took the same patients in this study and scanned them repeatedly 4 times over a year, and we made a movie out of it, which at that time I think traveled around the obesity conferences quite a lot, because it was really the first time you could visualize weight loss in this way. So 1 second here of the movie equals 1 month following bariatric surgery. And in this case, the patient lost around 45 kilos of weight in total. But we can then study what happens on adipose tissue, what's happening on muscle mass, etc. But not only that, it also gave us then very early on the ability to look into other specific tissues, like what you see to the right, subcutaneous adipose tissue, SAT, and visceral adipose tissue, where you see a very rapid reduction in visceral adipose tissue that you mobilize fast. But also, in this case, we call it IHCL, intrahepatocellular lipid levels. Now we say PDFF, meaning liver fat. But this is what we did 20 years ago. And you could see in this cohort of patients undergoing bariatric surgery, we saw about a 90% reduction in liver fat after 12 months. And what you see also, which I think is interesting, again, you see the dramatic reduction in insulin levels, in plasma insulin levels, and a biphasic, of course, because of all the lipolysis going on, and initial increase in FFAs, and a reduction in glucose in this case. So this study was actually, we thought was quite important, because nowadays we do a lot of work in weight loss in relation to liver disease. And the question has come back now, so where does the weight loss come from? So we actually, this should be EASL 2023, I'm sorry for missing that. It almost says EASL 20 here, but we actually went back and reanalyzed this data, which is 20 years old, to understand where does the weight loss come from, and is there a time dependency here? And I think the answer is yes. So we had whole body MRI scans looking at the baseline 1 month, 6 months, and 12 months post bariatric surgery. And if you look in the relative terms, you can see what's happening after 1 month. 37% of the weight loss comes from non-adipose tissue, while after 12 months, it's only 20%. And I think the reason for this is that initially, in the acute or semi-acute phase, you lose actually a lot of water early on, and you also reduce glycogen that binds a lot of water, which will look like a loss of muscle or lean tissue, while after 12 months, as you can see, the vast majority, 80% of the weight loss is actually adipose tissue and not lean tissue. So I think it's important to keep that in mind if you study this, that it is a dynamic effect that changes over time, and you shouldn't draw conclusions from two short-term studies in this field. Following that, we've done a lot of additional developed these methodologies. So we'll look at whole body MRI today with AI-based techniques. What you see to the left, where you very fast can analyze total adipose tissue, free mass, visceral adipose tissue, subcutaneous adipose tissue. And what you see up to the right is again AI-based technology that we have developed and we use in clinical trials, where we automatically segment all the individual muscles, so we can also study what are drug effects on fast twitch versus slow twitch muscle, because you may have mitochondrial effects that you want to study. But we could also study some of these effects directly. What you see, this is an old paper that I show you here, but the methodology we still use in clinical trials to understand mitochondrial function. So what you do here is to looking at, you can see over time, we put patients into MRI and we let them work, and we can see how inorganic phosphate starts to increase while phosphocreatinine goes down to maintain ATP levels. And then we can look at recovery of phosphocreatinine as a marker of mitochondrial function, which I think in the end is really what's important. We talk about a lot about muscle composition, but in the end you want to understand how well does the muscles actually work. So I think there's the technology here offers some really nice opportunities to study these effects of weight loss, but also if you lose lean tissue, what is happening, what is water, what is glycogen, and what is happening to the mitochondrial function. You can of course also study a lot of other ectopic fat depots with imaging. These are other examples of things being studied in clinical trials. Liver fat is obvious, we know that, and it's done, it's like included in every trial. But all these different adipose tissue compartments, there's a lot of interest I mean, we've been doing visceral and subcutaneous adipose tissue for 20 years, but there's now a lot of interest growing in perirenal fat, but also in renal sinus fat, as it's believed that this adipose tissue compartment also will expose the kidney or the vessels to increased pressure, and the reduction in renal sinus fat could be a good thing. We're also running, there's also trials looking at changes in epicardial fat, as you see to the right. And the reason this is important is that if you have to carry that additional weight every heartbeat, this could be associated also with the development of heart failure with preserved ejection fraction, or HFpEF, which is common in obese and diabetic subjects. And then, of course, the muscle composition. Muscle is not just muscle. You can do the composition piece here, looking at thigh muscle volume, contractile muscle volume, intramuscular fat. And it's important to remember that when you look at intramuscular fat, it's not only, you have to separate, and you cannot do that with imaging, the intramyocellular from the extramyocellular fat. And it was shown very early on by Schulman and colleagues from Yale, how it's the intramyocellular lipids which are primarily associated with insulin resistance, and not so much the extramyocellular lipids. With the simple imaging techniques, we can't discriminate intramyocellular from extramyocellular. But with the MRI, advanced MRI methods such as spectroscopy, we can separate those two. Now, knowing what we did, what we've done on the whole body imaging methodology to look at body composition, but also knowing how important from the Swedish obese study that plasma insulin level was on future events and insulin resistance. We wanted to also see, because when you do, the gold standard for studying insulin resistance is the hyperinsulinemic euglycemic clamp. Now, when you do, for those of you who are not familiar with it, what we do is that we have, of course, I mean, you have the pancreas producing plasma insulin, but we do an insulin infusion to increase the plasma insulin, which will shut down the endogenous glucose production, but then and you will lower plasma glucose. But then you measure the plasma glucose and counteract that by a glucose infusion, which you adjust the speed to that you reach a steady state at euglycemia. And that rate that you actually infuse the glucose with is the same rate, obviously, then that the glucose disappears from the body. So now we're in steady state, and that is what we call the hyperinsulinemic euglycemic clamp. So what we've done is that we then developed a methodology where we can take the patient when in the clamped state, and that takes about 90 minutes. We move them into a PET MRI scanner or a PET scanner like there will be at the Sanel Stravitz Institute. So now we're in the clamped situation. We move them in and we do dynamic PET imaging, and while we give the labeled glucose. This is regular FDG, which is the most commonly used PET tracer. But by doing this dynamic PET, we can now quantify the glucose uptake rate in any part of the body. So the map that you see to the right here is the glucose uptake rate map, where the intensity in every pixel is a quantitative number of the glucose uptake rate, where you can see high uptake in muscles, but you can also study it, what's happening in the brain, what's happening in adipose. And then if you now treat with different novel treatments, we can see all the tissue-specific effects on glucose uptake and not just the global effects which we have been able to study before. So here is an example which we published 5-6 years ago, where what you see here, we order them. The number that you see here below each subject is the glucose, the global glucose, or the M value, the glucose disposal rate. So you can see that if you have a very low number here, most to the left, 1.96, it means that your glucose disposal rate is low. You get rid of the glucose slowly out of your bloodstream, while the most insulin sensitive subject to the right has a very high glucose disposal rate. And now we just order them, as you can see, according to the glucose disposal rate. And now what the images you see on each individual subject here is the glucose disposal rate map. And now we can see that some subjects, I mean, if you're starting from the right, they have much higher signal indicating higher glucose uptake rate. And to the left, you see the most insulin resistant subjects. So now you can really visualize and quantify the glucose uptake rate in any tissue of the body. And one of the interesting observations we did here was that, as you can see here, is that in the brain it's going in the opposite direction. And that's quantitative and statistically significant, that we see in the most insulin resistant subject, in their hyperinsulinemic state, we see an increased glucose uptake rate in the brain, while a reduced glucose uptake rate in the rest of the body. And I will come back to this. So we put this into interventional trials. This is an example of an SGLT2 inhibitor, where at that time we thought it could potentially increase insulin sensitivity. We did not see that. We did not see it on the global level, nor on the tissue-specific level. What we did see was some reduction, because there is associated with weight loss of some adipose tissue reduction of visceral and subcutaneous adipose tissue, and some reduction of liver fat. A lot of the modern technology or drugs being in clinical development are based on incretins. And we know GLP-1 has been around for a long time, but there's also a combination now of GLP-1 and glucagon, and GLP-1 and GIP, and GLP-1 glucagon GIP, and GLP-1 and amylin. And we started to work in this field quite early on. We actually came into this because we wanted to use the GLP-1 receptor agonist. In that case, we took exendin because we wanted to study beta cells, because we know that the GLP-1 receptor was expressed on beta cells. So we came into this, we started in 2006 doing imaging of trying to quantify beta cell mass. It turned out that this specific PET tracer, so we used the exendin backbone and label it with gallium so we can look at the binding of the receptors. It didn't really work for beta cell imaging because it worked beautiful in rodents, but as we worked our way up to higher order species in cynomolgus and humans, we saw that there is a lot of GLP-1 expression also in the exocrine pancreas. So it didn't work for that. But where we did see a very good utility for this was that we could use it to really understand target engagement and receptor occupancy in drug development. So what you see in the GLP-1 curve here, in the image, you see the pancreas lightening up, and that's the baseline expression of GLP-1 receptors in the pancreas. And then as we give competing doses of drug, you can see how the signal go down in the red curve here as a sign of displacing the signal from the tracer with the native drug. And here we can really see that at a certain point you occupied 100% of the receptors, and there's no meaning to go any higher. It would only induce safety effects or tolerability effects. And then you can of course combine this with pharmacodynamic readouts, which is specific to that receptor. And this is, we get a lot of discussions around this. Another study, and I'll come back to that, was so we developed, I should say that first, we also developed PET tracers targeting the glucagon receptor, which you see here. Here you see the glucagon receptor expression in a patient with type 2 diabetes, where you see the liver now shining up in green, which is really the glucagon receptor density that we image. And we can then look at downstream pharmacodynamic readouts. If you hit the glucagon receptor, which you do with some of these drugs, what are the effects in this case? And I'll show you this in a moment in another image, but we look at liver glycogen effects. And the same, we haven't been using the GIP tracer in humans yet. We took that into cynomolgus studies, but there could also be potentially GIP-specific effects. This is, however, a little bit more unknown. But we also then, of course, know about the combined pharmacology, where you can look at liver fat and PDFF, which is done a lot, body composition with weight loss, cardiovascular effects or insulin resistance, like I talked about before. So this is just to show you an example of how we use this to study really pharmacology and PK. So if you have the pancreas, in this case, and the glucagon receptors of the liver, and you give a drug that will occupy the GLP-1 receptors, depending on the affinity of that specific drug, and the glucagon receptors, again, depending on the affinity to that receptor. So what we measure is the amount of free receptors at any given time. So when we give the PET tracers, the GLP-1 tracer will then bind only to a few receptors because there is a high receptor occupancy here, while the glucagon receptors may have a lower occupancy in this example, and you see a higher signal on drug. So we've been doing a lot of work on this. This is a paper we published in Cell Metabolism a few years back, looking into it. This is in cynomolgus. This is a triple agonist targeting GLP-1, GIP, and glucagon, where we could see the balance between the glucagon receptor occupancy versus the GLP-1 receptor occupancy. This drug was stopped in development. It's not, this was in collaboration with Sanofi. Sanofi withdrew and stopped basically all their programs in this field. And the reason I think they did that was because of this study, which we did, which was on the GLP-1 glucagon that they had at that moment. But I think it's very interesting how a small study can be very powerful in determining whether the drug works or not. So what we did here, this is a dual agonist targeting GLP-1 and glucagon, and we measured receptor occupancy in patients with type 2 diabetes. Again, baseline, you see in panel A, the receptor density or receptor expression of glucagon receptors in the liver. In panel B, you see the receptor expression of GLP-1 receptors in the pancreas. And note, you don't see any background signal from the liver. It's very specific to GLP-1, and you don't have GLP-1 expression in the liver. The kidneys shine up in red, and that's because these tracers are excreted via the kidney. They have a short vascular half-life, and you have a lot of signal in the kidneys. But fortunately, with three-dimensional imaging, as you see in panel D, where you see a lot of high signal in the kidneys, we can still separate the pancreas nicely from the kidney signal and then not being contaminated by it. So what you now see in panel C is the baseline glucagon expression in one slide of the liver. And in panel E, you see almost the same signal, very little displacement, meaning that the occupancy is quite low. While in panel D with this specific drug, there was a baseline in panel D, high signal, but a lot of displacement as you see in panel F, indicating a very high occupancy of the amount of receptors. And what we saw here, and this was a small study, it was in total we had less than 12 patients. But what we showed was that we had about a 50% occupancy on the GLP-1 receptor and about a 10% or 11% occupancy on the glucagon receptor. And there were really doubts whether there was any glucagon pharmacology with this low occupancy. And some clinical data indicated it was low. At the same time, I should say this was a once daily, where you have a much more variable pharmacodynamics. So there was a lot of tolerability issues here from nausea. But so they wanted to increase the dose to get more glucagon pharmacology. However, being at 50% occupancy already at this dose on the GLP-1 receptor, there was no chance that they could increase the dose with the tolerability issues they had and get any additional meaningful effect here. So they stopped the project just prior to phase 3. And I think that this is just a very nice example of how you can do a small study, really trying to tease out what is the drug doing and how is it binding to the receptors to guide decisions on future development. In the liver, we are doing a lot of work, and this is a simplified scheme, but this is just to show you how you with imaging, and this is not a complete picture, but we quite often use it. If you look in MASH, we start, it could be steatosis, but it could also be other reasons for your hepatitis. But in this case, we start with the liver fat, and of course, measuring liver fat is bread and butter in many of these trials. But there are advanced methods looking at also cell injury, where we use different methods depending on what is the mode of action of the drug. Gadoxetate is a method which we used a lot, and it was very recently reported something very nice data in an early stage trial. We don't know how it translates yet to the clinic, but showing that you maintain liver function in a PSC population. We use PET tracers, looking at immune cell recruitment. You can look at cytokines. I will talk a little bit about this PET tracer, which we think is very interesting, looking at fibroblast activation in the tissue in the liver, looking really at activated hepatic stellate cells. And then later, moving on, if you want to study fibrosis, there are PET tracers directly targeting collagen 1, or you can use, in this case, MRE or stiffness, other stiffness measurements to get a handle on fibrosis. But we're also involved in downstream imaging, looking at what's happening on the physiological side in portal hypertension, looking at spleen volumes and stiffnesses, portal blood flow, etc. And sorry, also finally, the endpoints, of course, HCCs with imaging we know, but we're also looking into quantification of ascites and varices, etc. So MRE has been around, PDFF has been around now for a long time, and as I mentioned, I'm not going to talk about that. Just one comment is that I think it's very useful if you look at MRE, that you also at the same time look at liver volumes, because we have done studies where we've seen, and we published those data. For instance, if you take patients with hypertriglyceridemia and you looking at phenofibrates, we actually see increase in liver volume and liver fat with that. So it's just that if things happen, the thing is with PDFF that it's really the ratio between water and fat that you image. And sometimes you could have an increase in water, and that will look like you decrease your liver fat. And then it's very good to know whether your liver volume actually increased, because that could be a sign of actually increasing liver glycogen that binds water as a control factor, and not just look at the PDFF alone. MRE has been around. We know it's not that sensitive at low grade fibrosis stages, but much more sensitive at the high grades, so 3 and 4. We're looking at the quantification of portal flow. In this case, what you see is a to the left, a cross-sectional image where you you can see the pulsatility of the portal system, and what you see here in the middle panel, in the middle arrow, is the pulsatility on the portal vein. And what you see here is then how we measure the portal flow over the cardiac cycle. The two other arrows I just put in there to indicate that we can also measure flow at the same time in the heart or in the aorta. And to the right, you see an arrow indicating the flow in the renal artery, which we do a lot of work on, also in hepatorenal syndromes, looking at what are the hemodynamic effects of treatments in both the portal artery and the renal arteries. And ascites I measured. This is just a plain MRI. You just quantify the ascites volumes to get an understanding whether treatment can affect your ascites volumes. We've also been doing work looking into spleen volume and stiffness. We know that spleen volumes goes up with this. Oops, this is very sensitive, my keyboard here. We know that spleen volumes goes up as a function of increased fibrosis stages. This is old data. And in the middle panel, I know that when I talk to Dr. Sanyal, that he says, well, spleen volumes doesn't really work. I think that depends on where we use it. And this is data I got from Massimo Pinzani, an old publication from his group. I think spleen volumes and spleen stiffness is still fairly linear up to the once until you get decompensated. And I think the reason for that is that also the spleen gets fibrotic if you have long-standing portal hypertension. But in this in the compensated state, there is still a fairly nice linear relationship, as you can see here. And to study that, we went back also to see if there was a relationship. And this is study that we presented at the European Liver Meeting 2 years ago, where we trained an AI algorithm to look at spleen volumes in UK Biobank, where we had MRI data from 38,000 subjects. And we just looked at the relationship between spleen volume and liver fat to see if you already in the preclinical state, subclinical state, can see a correlation. And blue line is male and the red line is females. And you can see with increasing liver fat, there is also an increase in spleen volume. I mean, we don't know, this was hypothesis generating, that we could think that, well, if you see a reduction in spleen volume early on, that could be indicative of reduced portal pressure in the subclinical range. I mean, these are not portal hypertension, I must stress that. So to test that hypothesis, this is a study we did with an FGF21 analog. We went back and asked if we could reanalyze the data to look at spleen volumes. In this case, there was about a 75% reduction in liver fat upon treatment. And we said, let's look at the spleen volumes. And what we found here, and we presented this together with Rohit Lumba at the AASLD in 2021, that you can see a reduction in spleen volume upon treatment at day 50 and furthermore at day 92. And to the right, you can actually see a movie where we delineated the spleen in red, and the white lines indicate the original size of the spleen, and you can see here how it shrinks. I think it's important to say that we may not think, or we don't know, if these are antifibrotic effects. First of all, we don't know for sure whether this is a pressure effect. So that's number one. But if it is, we also don't know whether it's a vascular or a fibrotic effect. I think depending on this, where you are in the disease, I mean, Dave Important and others from Cambridge said that at least in the portal hypertension state, that about 30% of the resistance comes our vascular effect and 70% are fibrotic effects. I think in the early state, it may be more vascular resistance than fibrotic resistance. So there's still things to learn here, but this is just a hypothesis generating work that we did to trying to look into spleen volumes and using that to understand the early effects on potentially reduced portal pressure. I also mentioned that we do other mechanistic work. This is a study we just published 2 months ago in Nature Metabolism. This is again a GLP-1 glucagon drug that we investigated, where in this case we did not use the tracer approach, but we wanted to use a more physiological readout to see whether you hit the glucagon target with this drug. I should say this drug was later stopped. This was a once daily, but I think for other reasons. But what was really nice, we took the same patients as you can see to the right and looked, and with the carbon-13 spectroscopy, we measured liver glycogen. And as you can see, we took the same patient. This was quite an heroic study from the patient's perspective. We took the same patients and scanned them 5 times in 24 hours. And did that at baseline and after 29 days of treatment. And this was both a target engagement study in the sense that if we hit the glucagon receptor, we should see a reduction in liver glycogen. But it was also a safety study, because if you hit the glucagon receptor too hard, you may deplete the liver on glycogen. And then it becomes a safety issue where you could induce more hypos or hypoglycemia. So what we saw here was actually a normalization of liver glycogen. You can see in the purple lines how liver glycogen went down from 350 to 250 millimoles per liter, which is a fairly normal, while in type 2s we see an increase in liver glycogen. So this is another way how we can assess drug effects. And I want to finish off here, I think, by saying, I mean, we know all the GLP-1s. We did a study on the effects on semaglutide on liver and body composition in NASH patients, which we published. And we did not see any effect we saw a 65% reduction in liver fat, but there was no effect on liver stiffness. And this was also shown in the separate biopsy study, that there was no reduction in fibrosis with semaglutide treatment. We saw also here, I want to show you just, I think this is important when you analyze this data, that the liver volume went down almost by 20%. And if you see liver volume reductions because you reduce fat, that means that the concentration of everything else will increase. So if you have collagen in the liver and you don't reduce that, you could even see, we have seen in studies where you see increase in stiffness. And we think that is simply by reduction of liver volume and hence increasing the concentration or the density of collagen if that is not removed at the same time frame. However, could there be other ways of assessing faster readouts and in fibrosis? And we know that fibrosis is the balance between fibrogenesis and fibrolysis. So we have there's a turnover of collagen all the time. However, if you have too much fibrogenesis going on and not increasing your fibrolysis, you will get the buildup of fibrosis. And that's what we indicate in this schematic to the right, where if you turn on fibrogenesis, the blue line, you will start to progress the disease. But if you turn off fibrogenesis, you stop the formation of new fibrosis, but it may take much, much longer to get rid of the fibrosis you have built up. But at least we should be able to see inhibition of progression of disease. And can we study this? Well, the work we've done and published, we developed a small molecule, an affibody molecule. It's a 7 kilodalton peptide, which we label with gallium, and we tried different functionalizations. It has a very high affinity for the human receptor, as you see here, 200 picomole, less for the murine receptor, but enough to still do some preclinical work. What we see here to the left is that these are human sections of liver fibrosis with grade 1, grade 2, grade 3. We have the PDGFR beta immunohistochemistry. Sorry, I forgot to say that this peptide targets PDGFR beta receptor, and PDGFR beta has been shown. There's been a lot of work by Scott Friedman showing how that is increased in activated hepatic stellate cells. So we think it's a good target to showing stellate cell activation. So what we see here in the series red staining, increased fibrosis. We also see increase in PDGFR beta expression by immunohistochemistry, and this is when we take these human sections and incubate them with a tracer. We can also see increased binding, and this is published data. And this, I think, is really the really exciting new stuff. And we will be testing this in humans for the first time in 2 months. And we're also really hoping that we can test this now when we're building the imaging core together with Dr. Sanyal at the Liver Center. But what you see here to the in the panel A is the signal in a rat liver where it's very low at baseline, and then we pre-treatment to block the receptors, and of course we shouldn't see a difference really. However, after 6 weeks of carbon tetrachloride, I mean, this is not a MASH model, this is a fibrosis model to just induce fibrosis. We know that. I mean, this is no diets or anything on this one. But what we see now is a massive increase in signal in the liver, indicating upregulation of PDGFR beta and activation of hepatic stellate cells. And if we pre-treat the animal, we can see that we can block the signal with cold substance or PDGFR beta, showing that it's specific to PDGFR beta. And lately we've also done regression studies, and here, if you can see on the panel C, you see the high signal in the liver again after 6 weeks of treatment. But if we take away the insult, the carbon tetrachloride treatment, we see that after 2 weeks that we have turned down the PDGFR beta expression, and hence we believe also the fibrogenesis. And this is just the same thing, but now in graphs. But it's also associated, as you can see here in this model, how we, after 1 week of regression, there is still some PDGFR beta expression, and after 2 weeks of regression, we really turn down PDGFR beta expression. So by that, I would like to thank you for your attention. I think that's what I wanted to present today, and I'm happy to take any questions.
Wonderful. Thank you so much, Dr. Johansson. We have a question in the chat here from Dr. Syme. Dr. Patricia Syme is our Department of Internal Medicine chair. She asks, can you please expand on fibrosis and stiffness measures? We're very interested in this in the lung in addition to the liver. Do you have any comments?
Yeah, I think, I mean, I don't have any experience of stiffness measures. I'm not sure if the question relates to lung, but what we have done, we have very nice data, and I didn't show that here, looking at fibrogenesis also in the lung. Obviously, I mean, there may be a different subset of fibroblasts if they're parasite derived or not, but I think it's very interesting question whether we could use the same tracer, and we are planning to do some clinical experiments after we do the first clinical testing in humans with MASH to move on also into lung fibrosis. So I think it's a very good question, and we would be extremely interested to collaborate with you on this, Dr. Syme. And this is typically something we could set up and do in Richmond in the near future.
Great. Thank you so much. Any other questions? Sorry, go ahead.
I could just add that we just very recently, also only 3 days ago, got very early initial data that it seems to be working also in myocardial fibrosis, or fibrogenesis, I should say. So that's very exciting data. Yeah, sorry for interrupting.
No worries. Anybody else with comments, questions? Feel free to ask to be unmuted, and we can have you all join the conversation. We have another question in the chat here. Have you found any differences in muscle mass loss when comparing different means of weight loss? Do all means of weight loss lead to about 1 pound of muscle mass loss for every 3 pounds of weight loss? Or is this worsened if the rate of weight loss is faster, such as after bariatric surgery? How are the NUSC stacking up for mediating muscle mass loss? Any comments? This is from Dr. Mayer.
No, it's a very good question and a very hot topic at the moment, and we are involved in different studies. I think if you do, there may be differences depending on the mode of action that you lose weight with. I mean, I must say in bariatric surgery, what we saw in the end in our data was that 20% of the weight loss was lean tissue loss. If you look into the GLP-1 data with DEXA, and you have to be a little careful, you can't compare MRI and DEXA. If you look in the step 1 trial with semaglutide, they reported 39% reduction of lean tissue. We have published some papers together with Vanderbilt some 10 years ago comparing MRI and DEXA, and I think it's fair to say that you can overestimate, that the DEXA overestimates loss of lean tissue by around 20 to 30%, depending on baseline BMI. So you have to be a little careful when you compare, but I think there could definitely be differences in loss of lean tissue depending on the mode of action. Also, if you as you saw, and we don't know the reason exactly for this, I should say, and we don't know if it means really anything, because I don't think the proper study have been done. But of course, if you lose loss by caloric restriction or by GLP-1, could be differences, and especially related to insulin levels, etc. So we still don't know. This is still early days, and we don't know the meaning, because I don't think the proper study really have been done comparing different weight loss regimes in terms of walking tests or muscle function, which in the end I think is really the important piece here.
Thank you. Dr. Syme, did you have another comment?
Yes, I just wanted to say thank you for the presentation, and we're very excited to look at fibrosis across organs. So we have groups, as you know, I think we've talked a little bit before on the lung as well as the heart and the liver. So very excited into being able to look in real time at fibrosis and stiffness measures. We've lots of interesting data about how stiffness impacts fibrogenesis. So I think there's lots of potential amazing things we can do in the future. So I appreciate you coming and presenting.
Thank you.
Thank you so much. Any other comments? I think we're at the top of the hour. I want to say thank you, Dr. Johansson, on behalf of the Department of Internal Medicine here at VCU. We appreciate you taking an opportunity to share your knowledge, and we'll be in touch, I'm sure.
Yes. Thank you so much.
Thank you so much. For everyone else, that concludes the Department of Internal Medicine Grand Rounds. The continuing education code will be up on the screen in a minute. Thanks for your time.